Okay, maybe I'll ask Dr. Lim a question first. How long has SCT been practiced worldwide? How many procedures are performed yearly worldwide?
Hi. So I think we both mentioned, I think the technology has been around for a long time. And in fact, I think the first attempt at doing a transplant happened, I think, in 1957. But as Anselm said, as with all these new technologies, it took actually almost 10 years before it became an established and successful treatment. But it's been more than 50 years it's been doing. And now at the moment, more than 50,000 transplants are done worldwide.
Wow. So what are the success rates of SCT for different diseases, Dr. Lim?
Yeah, that's quite very much depends on the different type of diseases, you're right. So I think for many standard indications that we transplant, the success rates are very high now, as Anselm and I showed earlier on. So for example, for acute leukemia, which is one of the main indications now, if you're responded well to chemotherapy and you're going to a transplant, your chances of cure are in the range of 70% or more if you're young, and even for diseases such as aplastic anemia, which is non-malignant, your cure rates are 80 to 90% for that. So that's for adults.
Yeah, I think there is actually quite a wide variety of success rates. I mean, if we select the best disease, best candidate, and the best donors, like thalassemia, matched sibling, we are now having a success rate of 93% for thalassemia and sickle cell anemia, which is very impressive. Imagine without transplant, they all die in their 20s or even sometimes in their teenagers. At the other end of the spectrum, for patients who have very refractory anemia, just as what you have mentioned, and there's no donor except for unrelated donor or sometimes haploidentical donors, and you go for a transplant, the chance of a success may be barely at 10%. Okay, but without transplant, the patient maybe would die in the next 1 month or 2 months. That 10% is a lot for that patient, compared with 90% to a thalassemia, because this is not something that would immediately kill them. But for very refractory illnesses, that 10% would make a lot of difference to the patient. And interestingly, if you look at a lot of places like Hong Kong, where I've been practicing, transplantation is only offered from the public hospital system. And in public hospital system, we always have a very long list of patients waiting for transplant. And obviously, to maximize the economic use of transplantation in your country, which is a subsidized healthcare, we always turn the transplant program to patients with a higher chance of success. In other words, if you come with a very bad leukemia and you want to go for a very high-risk procedure or transplantation in the public hospital, you will be given a very low priority. And many a time you may not be able to be offered a transplantation in the public health system as well. So that is why in some countries, the private healthcare system actually offer more help to patients who are very needy for transplantation.
That's a question.
Hi, good afternoon, doctors. I'm Eleanor Leco from the Business Mirror in the Philippines. I have several questions. First, are you using stem cell for bone marrow transplantation because of the popularity of stem cell therapies nowadays? Because there are many clinics for stem cells that are sprouting like mushrooms all over the world, and a lot of known personalities, especially in Hollywood, they're getting this regenerative medicine as a maintenance for their health and for their beauty. That's one. And the other, how do you compare your stem cell treatment with others? There are so many sources for stem cells. They have the sheep. I know you know that. That's one in Germany, and they also do that. They also use that for leukemia. And the other one is, what is the success? How do you compare the success rate of a patient who is a Caucasian and then an Asian, disregarding the rate of the donors? Thank you.
Okay, yes. To answer that, I think firstly, maybe to just clarify some things. I think that you're right. There's been a lot of interest in the public about cellular therapy and things that it can do from there. So I think what we're talking today about is about hematopoietic stem cell transplants. So it's specifically for treating patients with certain disorders, and we're using stem cells from the blood for treating these quite often life-threatening disorders. Yeah. So this is always from the blood. I know there's a whole other field of what we call regenerative therapy, and that's quite separate from what we do. And there's different the evidence base for that is slightly less, depending on what you're talking about. And so I'm probably not going to go into much detail about that. But regenerative medicine is quite different from what we're doing here. So in terms of the stem cell source, what we do, it will always be from human, because that's the only thing that will regenerate in humans. Anything, and it has to be a matched or well-matched donor or a 50% matched donor from there for it to work. Other therapies, from the best of our knowledge, certainly there's no published literature, trials, or evidence to suggest that sources otherwise works in the treatment of leukemia. Even sheep or things, as far as I know, and we attend all the conferences, I can tell you there's no evidence to suggest that they actually work for leukemia. I understand there's a lot of interest in the region in these therapies, so certainly my opinion in the field of blood cancers, for example, and cancers is that there is very little evidence to suggest that it works from there. Okay? Your other question is regarding Caucasians versus Asians. Do you want to answer? We'll take turns.
From our experience, where we have treated children from the Middle East, from India, from Russia, from Malaysia, even Caucasian children, we don't see any difference in terms of outcome. So far as the donor matching and the disease characteristic is concerned, the clinical course, complications, and success is about the same.
There's a question?
Yes. I'm Dr. Zodam, a medical journalist from Myanmar. And now I see your explanation very much advances in stem cell transplant in treatment of the hematopoietic diseases of the children. In literature, I have also read about some organ disease like a tumor of the head of the pancreas, and also some myocardia infarcted cell. They can be replaced by the stem cells like that. But nowadays, I don't know how much improvement in treatment of the big diseases like that. For example, the Patrick Swayze is a famous American movie star. He died of the head of the pancreas. Even in the very fully developed nation like in United States, they cannot save his life. And I want to know what technologically difficulty by the stem cell replacement in treatment of these diseases like that.
Okay, so a few things. So I'll let Ansem talk about stem cell transplant in pediatric. There's many solid tumors which kind of respond to transplant, and I'll let him talk about that. We talk about pancreatic cancer, I think. So stem cell transplant relies on the fact, a lot of it relies on the fact that one, you're giving chemotherapy to treat the disease, but two, you're relying on the fact that when you have donor cells from another person coming into your body, these donor cells can identify the cancer and destroy the leukemia or the lymphoma. This is what we call the graft versus disease effect. Yeah. We know that this is very strong in blood disorders, particular blood disorders, some lymphomas, but the evidence we have is that it doesn't really work very well. There's a very weak, or in fact sometimes no, graft versus disease response in many adult solid tumors. Be it renal cell carcinoma, there's some evidence, but weak solid tumors, certainly there's nothing to suggest that from there. So because of that, we do not offer this for people with solid organ diseases like pancreatic cancer and other disorders, just because we know that in terms of the cellular immunotherapy, from that point of view, there's no effect. So the only effect you may give is from the chemotherapy you're giving, and we would not offer it because the toxicities will be far greater than any benefit compared with routine treatment. So that's why in solid tumors, for adult setting, we will not offer it. But for the pediatric setting,
In pediatric, we use a high-dose chemotherapy followed by autologous transplant, stem cell transplant, to treat conditions like neuroblastoma and other solid tumor that is disseminated or relapsing. The principle is based on two things. Number one is the tumor is still chemosensitive. That means they are still sensitive to chemotherapy. But we need to use a higher dose than normal to get them cured. But at the same time, if we do that, we are actually damaging the bone marrow at the same time. So we use the patient's own stem cell to rescue the damaged bone marrow. So this is the principle of autologous transplantation for solid tumors in children. There is also some growing evidence that the particular immune cells, the NK cells of the bloodstream, may have anti-tumor effect. So there are a lot of clinical trials going on in America, in Germany, trying to use NK cells from another individual as an anti-tumor cell for solid tumors after chemotherapy or radioimmunotherapy in that case. That one is still developing, but for sure, yes, we use it for solid tumor in children.
My name is Samad from Rep Office Cambodia. I have a few questions. One is, what is the cost of the stem cell transplantation? Second, how long will it take, and how many days that patient or donor should stay in Singapore? And the third one, does it require approval from transplantation authority in Singapore, like liver transplant or kidney transplant or not? Thank you.
Okay, my turn first. Okay, in children, if we are talking about autologous transplant, the estimated cost is around 100,000. If this is allogeneic, meaning that the donor is from another individual, we are talking something in the region of 200,000. And this is because of rather long stay in the hospital and the use of very sophisticated machines and chemotherapy to allow the donor graft to take. In general, if this is autologous transplant, the stay in the hospital is between 4 weeks to 5 weeks, including the period of time we run the chemotherapy. For allogeneic, the average is about 6 weeks in the hospital.
yeah, so similarly for adults, I think the stay in hospital sometimes a bit shorter for adults, but similarly for autologous transplants, it's anything from around $80,000, depending on the procedure. And again, for autologous transplants for adults, they tend to stay in a bit shorter, 3 to 4 weeks in general from there. And in many of these patients, if they're very fit and well, for autologous transplants, we now may actually even offer them an outpatient option where they come in daily for review. So this is selected patients, but when we do that, the cost is significantly lower. For allogeneic transplants, the cost is around 180 and above from there. Again, this is because they stay in hospital longer. They're usually in hospital for up to around 4 to 6 weeks. We tell them to be prepared for. For both type of transplants, we always prefer that the patients are willing to stay in Singapore for a period for monitoring after the transplant. And it depends case by case. Generally, we recommend for autologous transplants, they stay for at least another month after the transplant. For allogenic transplants, they need to be prepared to stay for 3 to 6 months. And partly it depends on how well they recover afterwards, because we have some patients who have stayed for longer. And one of the other important factors, which is why actually I try to build links with physicians around the area, region, is also depends on our confidence and our link with the physicians in the area. So there are certain countries where we built good relationships where the physicians in the receiving country know our expectations, what we do. Then sometimes we can facilitate for the patients to go back earlier and we get reports emailed or sent over to us on a weekly basis to monitor. So again, it's a case-by-case, region-by-region basis, but roughly be prepared to stay for 3 to 6 months from there. Okay. In terms of your question about registration, no. Across the world, bone marrow transplant does not require case-by-case approval, unlike liver organ transplants from there, because they're national registries for donors. That being said, I think all the data is recorded, and I think certainly everything is audited from there. Yeah.
Do we have any more questions? Okay, maybe I'll ask Dr. Lee a question. What are your personal achievements in transplantation?
I think I have shown you a lot already. My greatest achievement is patient recovery, and to see children grow up normally and have their own success and families. Last month, I just went back to Hong Kong to attend a wedding banquet. And this is one of my ex-patients with bone cancer who started his own family in Hong Kong. And to make things more interesting, this bone cancer patient is himself now an orthopedic surgeon. And he chose to go back to the unit where he had his operation when he was a child. So he's now working in the same unit where he had operation before. This is the kind of achievement that we want to see with every patient who came to us.
Any questions? Oh, yes. Over here.
I just want to know the survival rate or how long do these patients live?
When we look at cure, we are looking at very long-term survival. Okay, so if we talk about thalassemia, for example, the 90% I meant to you is 90% that they will survive in the adult without any problem. That means 10, 20, 30 years. So far, the first thalassemia transplant was actually done in 1981. So, and the patient is still surviving normally. So what I can tell you is that these patients can survive at least 30 years in normal life. Maybe a decade later, I can tell you more about that.
Yeah, I'm Dr. Santot from Myanmar, from the broadcasting media. Actually, I'm not clear about this thing, but I would like to know something from you. That is, when the neonate has been suffered from neonatal jaundice due to RH incompatibility, is that intervention will be beneficial when we use in the management of this in order to avoid connectors?
Neonatal jaundice.
Due to RH incompatibility.
The
RH incompatibility.
RH incompatibilities in relation to the transplant or?
In relation to the management of this neonatal jaundice neonate,
Okay.
in order to avoid suffering from connectors.
Okay. You probably, the best is actually to anticipate. If you have a rhesus negative mother, you start to monitor the baby in utero. And if they have any signs that the baby has anemia, by looking at the cranial blood flow, or sometimes if they have any edema in the body, you start intervention in utero. And one of the treatment is actually in utero blood transfusion. That can actually help to lessen the chance of severe anemia in utero. And we try to deliver the baby as early as possible before the jaundice is too bad. And after delivery, if the jaundice is really severe, we go directly for exchange transfusion, and that can prevent connectors. I hope I can answer your question.
Do we have, yes.
After the transplant, what are the treatments after, or maintenance medication, and then are there any instances that the leukemia or the bladder cancer recur?
Yeah, so certainly once patients, particularly if they've had an allogeneic transplant, the patients require very close monitoring for usually within the first year after the transplant. For a few reasons. One, even though the blood counts recover very quickly, their immune system actually takes far longer to recover. So in the first year, patients need to be monitored usually several times a week, at least at the beginning, because there's a risk of them catching viral infections, risk of their blood counts falling from there, and so they're on a variety of medications to protect them from there. The other thing that can happen is that after an allogeneic transplant, one of the complications that can develop is a condition called graft versus host disease. That's where the donor cells become too active and they can turn around and attack the patient's body. So for those reasons, patients remain on drugs to protect them from infections, as well as anti-rejection medications for a period after the transplant. One of the differences between this and solid organ transplants is that quite often in solid organ transplants, patients require to remain on immunosuppressive drugs for lifelong or for very long term. In bone marrow transplants, because you're actually transplanting the immune system, quite often the immune system can adapt with time. So in many cases, we try to wean off the immunosuppression, usually within several months after the transplant from there. That being said, patients need to be monitored very closely. In terms of relapse, you're right, it depends on the risk of the disease before the transplant. So in good risk patients, the risk may be 10-20%. In some patients with very aggressive refractory disease, like some of the patients I showed you just now, one of my patients, the risk may be as high as 50% or more. So in those cases, sometimes we monitor them very closely, or we may even give them additional preemptive treatment after the transplant to reduce the risk of the disease occurring.
How about the survival rate of someone who received a transplant from a relative compared to an unrelated donor? What is the survival rate?
So nowadays, the survival rates are pretty close. In the past, there used to be a very big gap between unrelated and matched donors, and that was because of the drugs we had and the monitoring and the complications. But with the drugs and technology we have now, the gap is very close now from there. So which is why generally if we can't get a sibling or a family matched donor, we do not have any hesitation in proceeding towards getting a matched unrelated donor. But ideally, the unrelated donor needs to be fully matched as well.
Do we have any more questions? Okay. If there's one more. Yes.
What about the ethical issue for unrelated?
Sorry, would you like to use the mic? Yeah.
I am Dr. Wei, Chief Editor of Health Digest Channel from Myanmar. What was the ethical issue for stem cell transplantation, especially for unrelated donor?
Yeah. So to answer your question, I mean, maybe similar to solid organ, for bone marrow transplants, the donor registries are very tightly regulated. So most of the big international registries are the ones that we tend to use. They are very well governed, well regulated. There are international regulations which exist regarding the selection, consent of donors, as well as things like infection screen and making sure that patients are consented properly before we use them. From our point of view, whenever we need to get an unrelated donor, we are always a third party. So all requests for unrelated donors will always go through a central registry. In Singapore, it's the Bone Marrow Donor Program, and they will be the intermediary who will speak with another donor program to procure a donor. So we will never know we will know the donor's age, the ethnicity and things which are important, but we do not know the donor's identity, neither does the patient from there. So that part's all very strictly governed from that point of view. Yeah.
What is the future of this technology in terms of donors, technology, the facilities, the doctors, and the disease itself?
I think what we have seen in the past 50 years is that the technology, especially the understanding of the biology and immunology of the blood system, has been advancing. So we are now, I would say, wiser and better in terms of selecting the donor, doing the necessary treatment to allow the donor and the recipient cell to live happily together. And in this way, we can cure more leukemia. We can extend patient recipient population into the more aged populations. and at the same time to keep an ever improving outcome.
Yeah, thank you. I'm Rianto from Kenhome, Medan. I want to ask, what is the difference of treating or hematopoietic stem cell transplant in adult and children? For instance, treating a patient of thalassemia for adult and children, is there any difference?
Okay.
Thank you.
The treatment principle is the same, but the patient will not be the same. As we know, thalassemia, as you get older, you get more complications. As I mentioned, iron toxicity accumulates with time. When you are 5 to 6 years old, the iron don't bother you, and you don't have to worry about too much about the iron. When you get into 15, 16 years old, about 1/3 of them already had heart diseases, and they require treatment for heart failure and even diabetes. If you are 25 or 26, the chance that you have a defective heart is very high. And these complications will determine the outcome of the transplant, because the chemotherapy we use and the infectious complications that come along with the transplant will be much harder to manage if you have an underlying heart or lung problem. That is why if you look at transplant for 5, 6-year-old, in general we have a 90% chance of success. When we start transplanting patients in their teenagers, the chance is about 70 to 80%. For adult transplant, you can probably expect something like 50 to 60% chance of success because of the difference in complications.
Thank you. Thank you, friends of the media, for joining us today. We hope you now have a better understanding of PCC Stem Cell Transplant Center.